Y'all care whether I'm down there or down here? All right. So I want to thank Dan Lackland and others for inviting me, and certainly enjoyed coming. Wished I could stay longer. But so Dan asked me to talk about the treatment of diabetes, but particularly the treatment of hypertension in patients with diabetes. So I added the "in hypertension" to the title here. My disclosures are that I do have a very small institutional grant from Eli Lilly having to do with a large diabetes cardiovascular outcome study, and have done some consulting for Sanofi and Takeda. So importantly, what I'm going to say here doesn't necessarily represent the position of the federal government, the VA, NIH, or others, or steering committees from Sprint or Accord, even though I think there's probably a lot of agreement, hopefully, in what I'm saying. So I thought we were going to have ARS type questions, so I'll just do this very briefly. You just heard about the ACCHA guideline, 2017 guideline from Dr. Carey, but the first question is, what is the recommendation for treatment, for systolic blood pressure goal treatment in patients with diabetes? 150, 140, 130, or 120? How many would say less than 150? Okay. Which is interesting because actually the most recent VA Department of Defense guideline does recommend less than 150, even for patients with diabetes. And I'll show you why that is. That's going to be changed soon. But how many would recommend less than 140? Or how many think the guideline said less than 140? How many think it said less than 130? How many think it said less than 120? Okay, so I probably don't need to give the lecture. So second one is, according to the ACCHA guideline, in patients with diabetes and hypertension, which classes of antihypertensive agents may be used first, either alone or in combination with each other? So what would be preferred? First is thiazide diuretics and beta blockers, then ACE inhibitors or ARBs and calcium blockers. Third is thiazide diuretics, beta blockers, ACE inhibitors or ARBs, calcium blockers. And fourth is thiazide diuretics, ACE inhibitors or ARBs, and calcium channel blockers. So how many would say A, B, C, and D? Okay, so I'm not going to go through all the evidence for this, but I want to be focused a little bit in the short amount of time we have, since I'm going to try and I'll mostly cover goals, but then go a little bit into medications. So diabetes is certainly, diabetes and hypertension are very closely related, much higher prevalence of one in the other, about 2/3 or more, depending on where you look, of patients with diabetes have hypertension. And having diabetes in people looking across blood pressure spectrum, and this happens to be the multiple risk factor intervention trial, and you can look at a lot of different databases, it about doubles the risk at every level, and also the risk is progressive, just as Dr. Carey showed you earlier, starting from very low levels of blood pressure and then going up. Now, older studies showed about a fourfold higher risk of cardiovascular disease in patients with diabetes, the Steve Hafner article in New England Journal, which you may remember. But that was really the old definition of hypertension, and I think in a Finnish population. So this is much more representative of what we see in America, but still there is certainly a marked increase in risk in people with diabetes. Now, before the Accord trial, I've summarized here what I think is most of the data as far as important studies on blood pressure goals, randomizing to 2 different blood pressure goals or more, and either subgroups of studies like SHEP and CISJUR, or studies that were or HOT, or studies that were specifically done in diabetics. And the theme is that really for systolic blood pressure, the only goals that have been shown to be beneficial was a goal of about 100, less than 150, even though no guidelines until the 2014 VA-DoD guidelines had ever recommended 150 as a goal in diabetics. As a matter of fact, even with all of this data, most guidelines were recommending 130 back in from 2000 to 2010. And then after ACCORD came out, it went up to 140 for most. For diastolic, what I don't have on here is studies like HDFP that showed in the diabetic subgroup that a goal of less than 90 was benefited, even in diabetics. So what we have is the HOT study and the UKPDS study as far as showing benefit. The ABCD trial really didn't show benefit, even though there was a mortality benefit, but it's a very small study. But most guidelines have not considered those studies as being valid enough for one reason or another. I actually think UKPDS is valid. The main objection to it, for example, by the JNC8 panel, was that there was both a systolic and diastolic goal in UKPDS. But rather than throwing both of those out, I would actually do the reverse and include both. So I think 85 might be reasonable, and actually the European guidelines do have recommended 85 in the past, and some others have. So then we did ACCORD BP, and as you may know, ACCORD was an even larger study looking at glycemia intervention, intensive versus standard glycemia, and showed that intensive glycemia actually increased mortality. And I don't think we still know to this day why that is. That was in over 10,000 patients. But within ACCORD, there was a lipid study and a hypertension study. So the hypertension study was in a little over 4,700 of the participants, and we randomized patients, just like we did in SPRINT, to a blood pressure goal of 120 versus 140, and did a very good job of getting to averages of 133.5 over 119 and getting good separation. So, and I won't go into a lot of details here, but the overall benefit was only 12%. So there was a benefit, it was 12%. I say there was a benefit. The confidence interval did not make it significant. But it was a wide confidence interval, not what we had intended, because what happened is that the event rates were half of what we had expected based on all the best evidence we had to look at that point. The primary outcome was cardiovascular death, stroke, and MI. And obviously since then we've expanded MACE outcomes, particularly in SPRINT. Stroke was significantly reduced, excuse me, going the wrong way here, by about 40%. But it was one of a variety of secondary outcomes, and so we didn't feel that we could claim, and certainly didn't publish, that we had shown benefit. But there were some interesting things going on in the study. And when we looked at the subgroups, even though there was no heterogeneity to any of the major pre-specified subgroups, there was this difference between those that were in the standard glycemia arm and those that were in intensive glycemia arm. And it's not, and so those in the standard glycemia arm, which was the arm that wasn't harmed, if you remember, from the major study, we actually showed about a 26% benefit, very similar to what we subsequently saw in SPRINT. But in the intensive arm, we didn't see a benefit. What's often overlooked is that ironically, it wasn't harm to the intensive blood pressure intervention or the glycemia intervention. If you look at the outcomes, and it's kind of hard to see up here, but basically the three groups that were in the intensive arm of either one had lower event rates than those that were in standard glycemia, standard blood pressure. And again, it wasn't quite statistically significant, and certainly a subgroup. This has been now looked at in a variety of studies. That initial observation we subsequently published. Karen Margolis was the first author on looking at the interactions amongst the various interventions. kind of a complicated paper, but this illustrates some of what we saw, and also some other authors not involved in ACCORD looked at, and I don't think they fully explained the rationale for this, but they looked at only those patients in the standard glycemia arm, and they looked at only those patients who would meet the SPRINT criteria for risk other than the diabetes. And so they showed a significant benefit to that group. So that's similar to what we saw, obviously, in the main thing. And then this has just been published within the last few weeks. It's online. Srini Badu and several of us have put together a paper that looked at a little more detail into these various aspects. And this is summarizing it, but it basically shows the same thing and we compared to SPRINT. So SPRINT, you can see this significant 26% reduction in cardiovascular events, 27% reduction in mortality. And what we saw is that for the standard glycemia subgroup in ACCORD, it looked very similar. And there was no heterogeneity, if you will, between those two groups, SPRINT and the standard glycemia arm in ACCORD. And whereas the intensive glycemia arm, we did not see benefit. So it's really getting at the same answers. So we went further in SPRINT, since there really are no other trials out there. We looked at patients with prediabetes, essentially. So we looked at people who had glucoses of 100 or greater, and we found that, that the results were very, very similar. And there was no significant difference between those with prediabetes. And actually, this does include a small percent of people that sneaked in to SPRINT that actually did have diabetes. But even if you took them out, it would be the same. And even a little bit greater benefit, if anything. So what's important, I think, about this is it's not suggesting that there's something qualitatively different about people with diabetes, that they would not benefit from blood pressure reduction, even to the same degree of 120, even though people have theorized that it's possible that diabetics would be harmed by getting the blood pressure down lower. And I think this suggests, and the analysis of ACCORD, that there is actually benefit. Now, that's not level A evidence. And so we need more data. The good thing is that there's now at least one. I'm aware of another study that was attempted to be done in South America that I don't think is going to get done as far as or completed as far as I know, but there's another study that is starting that is looking at lower blood pressure goals, very similar to the SPRINT, to the ACCORD blood pressure study. And then you've seen this meta-analysis already. Dr. Carey showed it, that just shows, and this is not just diabetics, but within this, there are a lot of diabetics in this meta-analysis, and again, showing that there's this suggestion, and other meta-analyses suggest the same thing, suggestion of benefit to going to lower levels in patients with diabetes. Last year, the ADA put out a position paper essentially recommending the 140/90 for most diabetics, or at least those at lower risk, and then 130/80 for those at higher risk. So based on some of the evidence that I just showed you. And then the ACC/AHA guideline recommends 130/80. The 130 is not level A, but it is a higher level of evidence than the 80. Again, the HOT study, most guidelines have felt that's not adequate because it was a retrospective subgroup analysis that wasn't pre-specified. But might suggest that going lower is beneficial, and certainly the meta-analyses might suggest that as well. And so, at least the way I would put it together is that I think that we have very solid evidence that 150/85 is benefited in diabetics, but the totality of evidence, if you will, certainly looking at meta-analyses and the other data that we've looked at, that less than 130/80 to 85 is reasonable. And then if you look at the ACCORD standard glycemia group and the SPRINT SPRINT eligible group in Accordion and the SPRINT pre-diabetic population really does suggest that even lower goals might be beneficial, but we need more data. And so I think the 130/80 goal is reasonable, particularly as long as we realize that there's not a lot of evidence at this point for the 80 diastolic, and certainly the goal should mostly be on systolic. Now, in terms of drugs, I'm just going to cover this very briefly. There are a variety of meta-analyses, and this isn't necessarily my favorite, but it illustrates what you see in a lot of meta-analyses, that to some degree it depends on what studies are put into the meta-analysis. So this suggests that, and this is only looking at the major classes of calcium blocker, ACE inhibitor, ARB, diuretic, and beta blocker. And at least in this meta-analysis, there are some differences. Certainly the diuretic is much better at preventing heart failure. I don't put much stock in this ARB heart failure confidence interval or a point estimate. And again, it depends on what you put in there. There's actually not been a diuretic versus ARB head-to-head study directly. And other meta-analyses suggest, for example, for stroke, that there may be more benefit for not only calcium blockers, which this suggests, but also for diuretics. I think even better is to look at large studies. And so this looks at the diabetic population, and Dr. Welton actually was the first author on this paper, looking at diabetics, non-diabetics here, comparing the calcium blocker, amlodipine versus chlorothalidone, and the pattern is very similar. And so you can see that in the non-diabetics, the heart failure is significantly better with the diuretic, but in diabetics, it's the same. Little bit of difference for some others, but for the most part, very similar. Similar benefits for both. For the ACE inhibitor, and this was certainly surprising to all of us to begin with, but the diuretic was actually better at preventing heart failure, and then the non-diabetics better at preventing stroke. Now, most of that benefit was in Black patients. But in the diabetics, the pattern is very similar, and there's no heterogeneity between the two. So if anything, the diuretic is better, but overall, it does look like the other drugs that were compared here, and as we saw in the meta-analysis, that most of the major classes do pretty well. Beta blockers, I didn't emphasize the data that much, but the beta blockers may not be as effective. And that's why the guidelines are now dropping the beta blockers. So here's what the ACC/AHA guidelines recommend, that in adults with diabetes and hypertension, all four of those classes can be used initially, are useful and effective, and that's high level of evidence. And then for those with diabetes and hypertension and albuminuria, then RAS blockers should be considered. And if you remember, the previous guidelines had recommended actually in all patients with CKD, so we can get our nephrologist to talk about that a little bit more. So I'm going to summarize then by saying that hypertension is present in a very high proportion of patients with diabetes, at least 2/3. Hypertension and diabetes confer a much enhanced risk of cardiovascular disease than either one alone. Clinical trial evidence and meta-analyses suggest that a systolic blood pressure goal of less than 120 to 130 and a diastolic goal of less than 80 to 85 are reasonable, and guidelines do seem to now be saying that more consistently. And then in patients with diabetes and hypertension, thiazide-type diuretics, ACE inhibitors or ARBs, calcium channel blockers, one of those should be initiated first. Obviously, many patients are going to need 2 and 3 drugs, so they can be used in combination. What I didn't go into is the fact, I mentioned it briefly, that African Americans don't respond as well for cardiovascular prevention with ACE inhibitors or ARBs, even in patients with diabetes. So I meant to include that in there. I think the data is actually even stronger for thiazide-type diuretics and diabetics. So unlike in previous times when a lot of people would avoid diuretics and diabetes, I think they're beneficial, and they're especially beneficial at preventing heart failure, and equally beneficial to the other classes in preventing other outcomes. So I will stop there. Thank you.